Hello, everyone. We are Amicus Brain. Amicus Brain Innovations is a digital health technology startup that has developed an AI-powered decision support platform that transforms how our aging adults make their critical long-term care decisions. And our digital advisors take the complexity out of dementia caregiving. Today, we bring you another candid conversation with Dr. Naganath Narasimhan Prem as part of our knowledge sharing series that are expert-led dialogues, providing a venue for knowledge exchange, caregiving tips, and solutions for family caregivers. So we are delighted to have you with us, Dr. Prem. Dr. Prem is a chief consultant of geriatric medicine and an elder care specialist, and founder of the Department of Geriatric Medicine at Jaslok Hospital in Mumbai, India. And Dr. Prem will share his insights about aging, dementia, and wellness. And so today's event will be facilitated by our Amicus Brains advisor and an experienced caregiver, Geeta Iyer. We will then conclude with question and answers from you all. So as you listen in, please use the chat to share your experiences. You can make comments and also raise your questions, and we will have a Q&A towards the end of the conversation. So you can record your questions on the chat as well. And now over to you, Geeta.
Thank you, Shri. And thank you, Dr. Prem, for joining us today. I know you're a very busy medical practitioner, and I've been trying to get you to our conversation for a while. So I'm glad you're able to join us today. So let's start. If you could just introduce yourself and also tell us about what geriatric medicine is and how you got into this specialty.
Yeah, so thanks a lot. Thank you. Thanks to Amicus Brain Innovations, and of course, thanks to Geeta, who's been in touch with me. So I met her.
Geeta is okay.
Yeah, okay. Who's been in touch with me for a while now, actually, and met her in one of our mental health webinars with caregiver Sati, if I remember rightly, on the mental health day. So yeah, I mean, I basically did my MBBS from Aurangabad, and then I did my MD in geriatric medicine from Amrita Institute of Medical Sciences, that is Kochi in Kerala. And then after that, I was a senior resident in the prestigious course All India Institute of Medical Sciences in New Delhi in the Department of Geriatric Medicine. And then there, of course, under the tutelage of Dr. A.B. Day, who's one of the, you can say, beyonds of geriatric medicine in India. And then I was this assistant professor there as well. And then in 2018, I, of course, came down to Bombay and started the Department of Geriatric Medicine in Jaslok in Mumbai. And yeah, I mean, to be very frank, when I was in my 11th and 12th and decided to take up even medicine, I didn't know much about geriatrics. And even during MBBS also, the exposure is only improving now. I mean, we have really sort of, as you can say, a group pushed for the younger individuals who are in their MBBS days to actually know about geriatrics, or else during our time, there were no specific real lectures as well, where geriatrics was covered, because pediatrics was always a separate subject in final year, but geriatrics was never professed as a separate branch. Even so, maybe earlier there was only 1 hour given to MBBS students to know about geriatrics, so which is very, very less, 1 lecture, that's it. Of course, things have changed and more people know. And in general, of course, once I obviously got an opportunity to go to Amrita. Before that, I talked to a lot of people, and even so, I will say the real thing about geriatrics is geriatrics in a way chose me, and I sort of learned on the way. And the fact that I've always been a bit quite respectful to older adults and sort of somehow had a bond with them helped me a lot. And in general, of course, but I always feel that you learn more from older adults and their experiences, because they are more experienced in life in all matters, and that gives a sense of satisfaction, of course, looking after them. Now, if you have to talk about the origin of geriatrics, I think in 1909, Ignace Leon Asher coined the term geriatrics, which is derived from geros and itrikos. Geros means old age and itrikos means healer. And he was of course of the view that if pediatrics is such a specialty, then older adults have always been a heterogeneous population and they need specific care. So it has to be a separate branch, and that's why he pushed really for it. If you have to talk about origins of geriatrics in India, I think in 1996, the first department and OPD of geriatrics was started in Madras Medical College, Chennai. And ironically, the second department was in Amrita, and I was the first candidate in Amrita to do MD in geriatric medicine. So, and of course, a lot of people have done it after me. Now, of course, it's spread to more almost. I mean, even in Bombay, there's MGM Medical College, in which, ironically, my wife did MD in geriatric medicine from there only. So she's also a geriatrician, and so it's only getting better. But I mean, for the amount of people who are getting older, we still are really short on human resource. And I think we are at least 20 to 30 years behind the US, because maybe in the 96 and US and England in 96, when they were talking about having more education in geriatrics, that is where we are now. So we are talking about more and more people being educated. So maybe around 20, 25 years, but yeah, I think we are getting there. I think sensitization is the key with geriatrics. And I think there's a huge sense of satisfaction, and ultimately you get a lot of blessings. So that is always sort of the case. So I think it's very fulfilling in a lot of ways. You can't treat everything. I think that is one reality, but you can manage. And I think that is one of the important, you can say, principles of managing older people. You have to manage them rather than maybe treating the diseases, which might not be always possible.
Yeah, so many of the things that you mentioned resonate with me totally. I have been taking care of my parents for a while. Now my dad passed away. He had Alzheimer's, and my mom is 93 now. So I've been living with the really old people for the last several years. And so I've seen many issues. So there are many challenges, both for them and for people who live with them. So can you talk about some of those challenges relating to aging, and how, what are some of the common ones that you see?
Yeah, I think one of the most important things to understand is the factors that actually, to a great extent, affect an older adult on how independent they are. So there are, it's a heterogeneous population, as I was saying, but not all older adults will need help. Some of them might need help for a basic amount of time, in which they might get ill and then they will come back to their original health, whereas some of them might need assistance forever. So I think the common link between these two types of older adults is health. So the healthier you are, the more independent you will be, and the lesser, the not more, if your health deteriorates, then of course you will be more dependent. So there are a lot of factors which actually sort of dominate that as far as aging process is concerned. Aging itself is not a disease. I think that is something which should be clarified very clearly, because a lot of older adults do think that it might be, maybe it's a small portion of it, but not all of them think that way, but there are significant amounts still thinking that way. So the most important thing with aging is it depends upon the number of diseases you have, the number of lifestyle you have, the lifestyle you have, then the number of medications, then what is your what is your social sort of relation, connections? Are you alone? Are you isolated? Then what about your genetics? Do you have any strong family history of any diseases? Have you had any sort of geriatric syndromes in the past, which are the sort of common diseases which are seen in older adults, especially dementia? Then there is something known as delirium, which is acute confusional state. Depression is very common. It is easily missed. Then falls. An older adult is very liable to fall depending upon the number of diseases they have, or maybe any disability they have. So the more dependent an older adult is, the more the chance that they might actually fall. Then another important thing is urinary incontinence. I think that is something which is not talked much by older adults themselves, because it has a distinct social taboo to it, and it limits their independence in them actually thinking of even going out. More and more older adults, but now have started wearing diapers and even trying to wear those diaper pants, which are more comfortable than even diapers, in which they are able to still maintain their level of independence. And they are able to take that choice. Earlier, maybe they were not, but now they are, because they obviously feel that they have to remain more independent. Then bed sores is another one. Bed sores, I think, shouldn't happen to anybody, purely because if that is happening, then you are bedridden, and that can be very difficult. Then frailty is another sort of entity in which a frail older adult, if he or she gets a disease, might not get back to normal health, whereas a person who's not frail will still be able to get back to normal health even after treatment. So for example, if somebody has a urinary tract infection, then they might not get back to their original thing even after treatment. Then I think one of the important things is one has to understand that it's an aging body. So health is also affected by that. All the organs of the body are aging. So if you're 80 years old, it has worked. It has almost grown from the womb to the first day of your life. And one has to realize that the day you are actually 1 year old is the time you're getting older. So old age does not suddenly set up. You're getting older every year. So it's only that above 60 that we divide it into this particular age group. Then if you talk about common diseases, apart from these, I think urinary tract infections and the pneumonias are quite common in older adults. Then apart from that, I think a lot of electrolyte disorders like hyponatremia, these are all very common ways in which older adults will present. Then there are the usuals which are like diabetes, hypertension, coronary artery disease, stroke, which are all sort of, I mean, interconnected in a lot of ways to being risk factors to all these major geriatric syndromes. So I think these in overview are sort of the most common problems which I have sort of encountered. Some problems which might be considered minor but are very major include constipation. I think constipation is very, very important. Then the three factors which really matter for the quality of life is vision, hearing, and teeth. They are very commonly missed. So in fact, when we do an interview with our older adult clients, the first thing you have to make sure is they got their hearing aid, or else the interview is as good as null and void if they have a hearing aid. So these things matter. Then the need of an assisted device, I think that is also very important, because a lot of older adults shy away from using it because they feel they will become dependent, rather than them thinking that they are more independent because of using them. So I think that's the thought process. It has to be an extension of your arm. It should not be thought as a burden.
You mentioned one thing, that aging is not itself not a disease. I mean, it's happening to us right from the time we take birth. We are aging every day. And also many of the diseases that you mentioned, nowadays they're occurring earlier also, not necessarily above 60. You hear about cardiovascular diseases in people who are in their 30s, or even dementia, but I mean, that's a different a different topic altogether. But how can we all of us who are moving towards that, prepare for a healthy life? So we want to, many of these things are avoidable. Many of the, I want to come to dementia because that is our focus. We want to focus on that, but mitigate many of the risk factors for that, as both physical and mental illnesses. So how can we, so we can
as you said, disease doesn't suddenly happen when you turn 60. It's a work in progress. So it actually starts due to your lifestyle, due to your habits from much before, maybe in your 30s and 30s, 40s, 50s. That's why we say that your yearly screening should always happen. I mean, it's good that corporates have come in. So most people do have a yearly health checkup anyways, but a lot of people don't get it done. Then if you have a family history of cancers, then I think that cancer screening should be done anyways, especially breast cancer. If there is a strong family history, the colon cancer, Then even to a great extent, if there is a strong family history of diabetes, I mean, these things have to be screened very thoroughly. Then I think one of the most important things is your habits. So it could be, extracurricular activities like the amount of drinking, whether it's social, whether you drink too much, the quantity of alcohol, then the amount of smoking, if at all you're smoking. I think smoking, to be very frank, has hardly any benefit. So it shouldn't be, in any ways propagated. But I mean, the earlier you stop it, the better it is. But it's not late as well. So if you're stopping at a later age, also it's not something which you should continue to do. Then I think the amount of water that you take, even that matters. I mean, the fluid amount that you take, then the diet. I think the diet is very important, in which, especially in older adults, we are more flexible. We want to avoid it being very low. The sugars, we want it to be at a level, but it has to be a good mixture of green leafy vegetables, fruits, then a lot of antioxidants in this way. I mean, I would want lesser supplements and more through diet, but there are challenges of the taste, there are challenges of lack of teeth. So then that is when the supplements obviously come in, and not everything would come through the diet per se. But I think diet is very important. Then the amount of sleep and the quality of sleep is very important. It's one of the real important risk factors even for dementia, because memory is something which is sort of strengthened in your sleep. So I mean, whenever you are preparing for something and you have a good night's sleep, it is better than you actually preparing throughout the night, because your all the facts and all the things are sort of made, the building blocks are made in your brain, and you're able to present it better, rather than you just logging throughout the night and not being more groggy and presenting the same. So I think sleep has always been important at any age. And as you grow older, even more so, quality and quantity both matter. So I think sleep is also another thing which is very important. Then I think physical exercise is neglected too much. It's like, if I'm okay, then I don't need to do exercise. And I used to do it earlier. Then so that what has happened is, especially during COVID, a lot of older adults have become sedentary, not because they want to, because they could not go out because they were the vulnerable population. A lot of older adults were smart enough to use their home space also for walking. And a lot of them who had roofs, I mean, I could see it from top, from especially, I mean, our hospital is at a higher tilt. So we saw a lot of lower buildings in which we could see older adults walking around in their terraces, in the roof. So even that was there. So a lot of modifications were done by themselves. So that's good, because sitting is the new smoking. So if you keep sitting, the sedentary life, then that will not be good. So I think that's one of the major risk factors, especially as middle-aged, adults. We are doing a lot of that. Work from home is not helped. Sitting at one place is not something which is good. Then always for cardiovascular diseases, I think family history also matters, but your sort of lifestyle matters. By lifestyle, I think stress is very important. The amount of stress you have, how do you take stress? Are you a person who's cool? Are you a person who takes things into stride? Then I think social networks and social connections matter a lot. That's also a significant risk factor for a lot of diseases, especially for aging as well. The more you can be, there is a difference between one person living alone and independent, and a person actually being isolated. A person can be isolated in a home of 4 as well, having no connect. But at the same time, a person who is living alone will not necessarily be isolated. He's very happy, he or she is very happy being there, independent. And then, of course, sort of going in public and meeting. So what really hit in COVID was that public sort of meeting people, getting chat. And of course, there is always a silver lining. The silver lining is me and you talking online now. Maybe this wouldn't have happened if there was no COVID. Because we didn't really think that we were going to meet people like this. People, of any hemisphere. If we were connected to the intergalactic system also, maybe we would have talked to different galaxies as well. Just on the lighter note, that's the way it has changed. And older adults have picked up technology, which is one of the biggest things which has sort of helped. Of course, comes with its challenges, especially people with dementia. It was very difficult for them to figure out technology, purely because, especially those who were seeing their own image, so they were getting confused, later stages of dementia. So all those things were there, but yeah, I mean, everything comes with its pros and cons. But telemedicine and telehealth has really helped. Again, that also has problems. A lot of youngsters have had back issues because it's been work home, sitting. So I think one of the most important things in what I sort of related is, I mean, as always for health, I think health is a state of physical, mental, and social well-being. So I think that's what should be focused upon when you think of risk factors for disease at any age. If you are able to keep these three parts strong, and any one of them goes weak, the other two have to be sort of they get a bit dicey as well. So I think that is what should be focused upon always, and how you are as an individual. Give yourself time. There should be a me time, whether it's meditation, whether it's songs, whether it's just cutting off from people, or whether it's going in public and talking to a lot of people. I mean, for example, when I also used to have a lot of presentations in public before. So recently I did one back in public. So the feeling was completely different as compared to just being sitting online, and you can see the numbers as even 100, but you don't know how many people you are actually interacting to. So I think that is also something very good. And I think geriatrics has always been an in-person thing, but I think the videos and this has really helped, because now we can reach people who otherwise we thought we couldn't. So I think that is one of the biggest silver linings. And as we go ahead, I think it will be all hybrid.
So Amicus Brain Innovations, their current main focus is developing AI-based technology solutions that would provide support and help to both dementia caregivers and also people living with dementia. So dementia is the focus. So can you talk to us about dementia, as age is definitely one of the many risk factors. And one of the myths that you often encounter is, it's normal, he's old, so this is all normal. So I think a lot of people don't get it diagnosed. And when we started, you said, we cannot control everything, but we can manage things. So, but to be able to manage, you need to know what you're dealing with. So can you tell us what dementia is, how it is different from just old age-related, memory loss, whatever many of us encounter, and even the process of diagnosis, why it is important.
The most important thing in dementia, I think, is to understand that dementia is not a disease. It's actually, dementia is not, it's no longer that subtext anyways. It's known as major neurocognitive disorders these days. And it is another very important thing is it's an umbrella term. It's not like a single disease. It also has reversible dementia. So for example, people with hypothyroidism, people with vitamin B12 deficiency, folic acid deficiency, an older adult having a fall, having a subdural hematoma, you remove the hematoma, the forgetfulness will go. Then NPH, which is normal pressure hydrocephalus, you treat the same, whether it's through surgery or through removing of lumbar tap. That is usually a person has urinary incontinence, dementia, along with imbalance in walking. So that's the triad in NPH. So that's also one of the reversible you can sort of improve. Then there are the real sort of frightening ones, which are the dreaded Ds, which are talked about always. Alzheimer's is obviously top. Then there are others like Parkinson's disease associated dementia, then frontotemporal dementia, dementia with Lewy bodies. Then there is also, of course, one of the very difficult to handle dementias is also FTDs. I think frontotemporal dementias is very difficult because there's a lot of behavioral change. And then another common dementia is vascular dementia, which will have a significant vascular factors like blood pressure, diabetes, hypertension, maybe a history of stroke, a history of any cardiovascular disease. So that will be a sort of in the background, and that might be vascular dementia. Now, what is important is that there has always been a general myth that all older adults will actually have forgetfulness. That itself is a myth. The reason being dementia or dementia, or I would say cognitive impairment is the better word, is not only about memory. Memory is the one. Memory can be memory is the one which invokes, I think, eyes. So that is what is talked about. But memory is not the only thing that goes. A person's personality can go. There can be a language problem, the way they talk, the speech, then taking care of themselves. Then there is something known as visual spatial orientation, in which a person will not be sort of able to understand what this particular thing is, even after seeing it. Then not understanding where they are. A person who used to calculate very well before is not able to calculate simple things. Not able to draw a clock with the time. Basically, make it's another visuospatial thing in which the person is not even able to. I mean, I have seen I've seen clocks which are not even seen. So it's made so badly because they are not understanding. So that is the level. So one has to understand. I mean, this is for the public to understand that dementia or cognitive impairment is not about only memory. Because when people only focus on the memory part, everybody says, no, the memory is okay. Everybody, he or she remembers everything of the past. But sometimes they forget things of the recent. That is the usual. Short-term memory loss is the usual. This, and then maybe it's a part of aging is what most people think, and they don't get screened. That is what really is the problem. Now, as a clinician, I want to get them at least at minimum cognitive impairment, that is MCI, so that if I can get them there, then I'm able to sort of do interventions, both pharmacological and non-pharmacological, and ultimately I might be able to at least arrest. If not, I mean, we all know that there is no reverse sort of thing, especially in Alzheimer's and the other cases. But if we can control the same, it's important. Now, one of the biggest differences that people should understand is age-related memory loss and a person actually having full-blown dementia, as we say. Now, age-related memory loss, people might have a bit of memory loss as they go. For example, occasionally a person might get lost trying to take the same sort of direction, but it comes back to you. But in a person who actually has dementia, the person will have no clue. So that will be total wandering. A person will not be able to even know that where they are, and become so difficult in such cases that because they are not even able to tell that where they want to go. And there have been cases like this also, because people have not realized the diagnosis is not done. So they just feel that the older adult just went off. Then forgetting names. If forgetting names and maybe even things, now if it doesn't come back to that particular person, then definitely it's dementia. For a lot of times, a person will be able to sort of recollect. They see the face, they are not able to, and then like, oh yeah, I saw that particular person. So it comes back. So that is basically more of age-related memory loss than anything else. Then I think to a great extent, understanding and comprehension of that particular thing. Even speech to a great extent, replying to a person, analyzing something, that will not be there at all as far as dementia is concerned. But you might be slow a bit, but you will be able to sort of do it taking your time if it is only age-related memory loss. Now, if you're given memory aids like writing things down, reinforcing again and again, then you will be able to remember in age-related memory loss. But in dementia, you will not be sort of able to even get to that particular point. The fact that there is any insight or even knowing in severe dementia, the person will not even know what's actually happening. Every day is sort of a new day, and the caregiver is the one, as you must be knowing, is the one who actually has to change their lifestyle and change the way into living for the person with dementia. So I think one of the most important things is, if there are symptoms, or if there aren't symptoms, I would still advocate people to get yourself checked, especially for a memory screening, especially in your 50s or at least early 60s, purely because maximum what will happen, maximum you will know it's normal, or you will obviously feel there is something wrong. And then that also, it's not, everybody has this misconception that all the tests will be done and everything will be, no, that's not the way things happen. Screening is done, and then we decide whether imaging has to be done or not, whether blood tests have to be done or not. And if we find out, it's a good time to find out, because then whatever treatment can be initiated, it can be initiated earlier. So I think that is very important, that everybody not only sensitizes them about what dementia is, but one should know when they should go to the doctor.
Yeah, and also I think you raise a very good point, because dementia, when you start seeing the symptoms, it's probably has been building up for a while. So earlier you catch it, the sooner you can do something about it. So another important point I want to highlight is it's not just memory loss. It's dementia is beyond all of that. There are many things involved, judgment and problem solving and comprehension. So you talked about screening and tests, and so that we can determine a course of action. So in India, or specifically Mumbai, where would they go? Like usually one of the challenges that many of us have, like when I started with my dad, I wouldn't have known. I was seeing a few things, and I had a sister. My sister is a physician, so she told me take him to a neurologist, and that's how it started. But many people don't know. So where do you even start? Do you go to a primary care physician? And that is another point I would like you to address. Many of them are not aware, so they're as clueless about dementia as us. So they just treat the medical, physical illnesses. So when it comes to mental illnesses, it's a problem. So where do they start? Who do they go to?
I think in general, the system in India to a great extent is that everybody. I mean, we expect older adults obviously to have a primary care physician for years, who might be a family physician, who might be. So I wouldn't say it's their inability to diagnose. It's just that they haven't been trained. So it's basically it's not that much amount of sensitization is even there to diagnose dementia. And in general, when sometimes it could be lack of knowledge or information, which can lead to the fact that just branding it on age. I mean, see, health has improved a lot in the last 20 years, and last 20-25 years before, maybe even dementia was supposed to be a death wish or a death trap. It's no longer is. I mean, there are a lot of non-pharmacological and pharmacological both. Yes, nobody wants anybody, but care is there in different levels. It is not only there at home, it is there in assisted living. It's all through India as well. I'm not even talking only about abroad. We have nursing homes, we have elder care, assisted living, especially pertaining to dementia. Then, of course, obviously, there are the hospitals. I am not always keen on getting a dementia patient admitted into the hospital because it might not always be the best case scenario for them, especially if they have an emergency, if they have an infection, we have no choice, but we have to admit them, treat that, and then sort of go. So I would say the pathway should be very clear. If the number of geriatricians also, unfortunately, are not much throughout India also, they're only coming up. Of course, it's completely different in the West. I mean, geriatrics the demand is also very high, and a lot of people are there as well. But it has taken its sort of due course and time. So I would say the family physician usually is the first so if a bit of training is given to them, yes, that works. But after that, I feel if they are not, which usually is the case, and most family physicians do that also. They immediately refer, and kudos to them for that. When you don't know what you're dealing with, you obviously refer. And that particular person is still their patient, in which they are obviously trying to take care of them in coordination with the specialist here, which could be anybody, which could be a geriatrician, or it could be a neurologist, or it could be a psychiatrist and a psychologist. Now, usually what I believe is it should be a multidisciplinary sort of intervention, because when specific things are needed, then of course neurologists might be needed, then psychologists might be needed, especially for the detailed psychological assessment for dementia, and then of course the interventions, which could be cognitive behavioral therapy, or which could be even reminiscence, mindfulness. So there's so much of non-pharmacological treatment which has sort of come. Art therapy, music therapy. I mean, there is so much which is there, which can be done with patients with dementia as well. And that is what is the most important thing that people should understand. At the same time, everything goes together. Drugs, as well as, I think, non-pharmacological, both should be initiated at the same time. It shouldn't be that, okay, now the drugs are given and then the non-pharmacological will be started. So it doesn't work. It doesn't work that way. And I think it should be more of a coordinated effort. And yeah, and it is getting, I think one of the biggest ways of doing things, of course, is setting up of memory clinics throughout sort of the place, wherein at least general public comes and get their memory screened. because the more the screening happens, the more diagnosis will happen. And then once the more diagnosis happens, then the more treatment, of course, the specialist will obviously be sort of involved. So the point is to make sure early detection is there, and at the same time, whatever appropriate treatment is there, that should be started.
That's great. Even in the West, I want you to address this point. As caregivers, I've started a support group, and I've been part of many support groups online. The general feeling, whether it is in the US or even here, that we get more support and we learn more from our peers, other caregivers, and other experts, YouTube videos, but the doctor, there is minimal involvement. So you mentioned this multidisciplinary approach. That is, I think it's very crucial, because we go to the neurologist, and then I never went back to her. After the diagnosis, there was no involvement from the doctor. For my dad, it was all what I learned from caregivers and other experts. So on that point, we had the last guest we had, she was herself living with dementia. And she mentioned something that, that relates to what you mentioned, what you just said. It is not a death sentence, but when the neurologist gave her a death sentence, so there was a lack of empathy and compassion, because what she mentioned was, if it's a cancer patient, they're sent home to live, well, manage it. But when it's dementia, there is no assistance. So I think it's heartening to hear what you're saying. You're saying that there is more awareness and there is a possibility of a multidisciplinary approach, and people don't have to go home to die. So if it's dementia, it does not have to be a death sentence. So how can you talk about living well with dementia? What does that mean? And it is not a death sentence. And what does it look like? What does living well with dementia look like?
Yeah, I think one of the most important things here is, the reason I said multidisciplinary is, I think it is one of the bases of geriatrics. Because when an older adult comes to me, I believe that I can sort of treat any ailment in that way, so that there is no stone left unturned. So whether it's involving a lot of other specialties, and usually it will be, because, for example, I'm not a dentist. So, and I know that the teeth is very, very important. I'm not an ophthalmologist. I'm not a ENT surgeon, but all these three things are so important for the quality of life. Hearing, of course, is one of the most significant risk factors for the development of cognitive impairment. So that's why that if somebody discovers a hearing loss earlier, it should be sort of addressed absolutely very early, so that it's a reversible cause. Again, you can correct hearing to a great extent, if not completely. Then I think one of the most important things is living with dementia. One is the level. I would never say dementia per se, purely because I don't know what the level the person is. So I would say cognitive impairment, because when it's severe dementia, the person doesn't know that the person themselves that they are living with dementia, because there is no sense of them realizing. But for a caregiver, it's very important that they realize that there is a person behind that disease, and it's not a disease that they're dealing with. Because when somebody gets dementia, especially your own kin or maybe even a near person to you, we focus on dementia a lot, because it just overwhelms, and we forget that there is still that particular person. And it's not there is a stage of denial initially, that how this might have sort of happened, but that a lot of people recover out of it. Obviously, I think education is the key. Now, for a caregiver to live with people with dementia, I think you have to get educated about the disease well, and not necessarily only through Google. It can be very scary. So as you said, I have been a part of a support group meeting, which I started in Jaslok, which was the first of a kind in Bombay for older adults. We started it in 2018. So to go and meet people with similar problems helps, because it's all, you can say, in a way, hit and trial. Not that what they did might work for you, but their experiences help you. So there are support groups specifically for caregivers of dementia also. So that is more specific, because that intervention will be more specific, and that dialogue will be completely different. Then another thing is, the caregiver should always take care of themselves, which is one of the very important things as far as dealing with a person with dementia is concerned. Now, if you have to put it brutally for the caregiver, the older adult who has severe dementia, there is no way of that. I mean, you getting a thank you or anything from that older adult, thanks for taking care of me, or even a realization that you have been taking care of. But the point is, I mean, it's not even an emotional statement that I'm making. The point is that that older person would have done the same for you when you were young, without even thinking about it. So but it's a challenge. I think that is something which one has to realize. That's why you can't do it alone. That's why there are professional caregivers, there are professional agencies. That is why a continuum of care is there, wherein if you can't handle that older adult at home, assisted living would be the best way. And I have seen people moving to assisted living and doing wonderfully better as compared to even home. Then a lot of relatives are like, "Arey, what was I doing wrong?" So I tell them, no, you were not doing anything wrong. It's just that the setting, the brain obviously has got adjusted to that particular setting, and they are much more happier there because activities are done, this are done. So it's a different set of things which you can't replicate at home. So that is why, because a lot of caregivers tend to get very, disappointed that what I was there a shortcoming in the way I can? No, there is no shortcoming, but it is a specialized care. So a specialized person trained in dementia care will do a better job. So if you, again, affordability is very important in India. If you can afford it, then you should go for assisted living because it's good. Another important thing for the person who is living with dementia, cognitive impairment, again, depending upon whether it's initial, you need to continue to give yourself memory aids, try to write down things, try to give yourself, for example, if you remember the movie Gajani, I would say they had just put it in that way. But then that's how you need to sort of, I wouldn't talk about what he had because that was just too, short-term memory loss was just too difficult to digest. But the fact that marks, aids, put up posters, put up photos, try to understand what is what. Depending upon a level of cognitive impairment, of course, you would be able to sort of, I'm not saying live independently, but with somebody's support, you would still have a better quality of life, which you have. And I think it's very, very important that when that you have that support when you are sort of getting more worse. So I think a social support is very, very sort of important. In fact, I feel empowering the older adults is the best way. When a person who's in a young old, for example, 60s, 70s, and they don't have any issues, can be a very good caregiver for a person who's 90-year-old with disease. So I think that itself is something which is really pushed. And I think the biggest human resource we have, which is untapped, is actually older. Because somehow it's always felt that after a certain age, contribution cannot happen. But I think that is absolutely not true.
Yeah, that's a good point, because and also you need a sense of purpose. People need a sense of purpose, and I'm also glad that you brought up caregivers. The caregiver burnout, and we need to set boundaries of what we can do, and not carry so much guilt, because all caregivers are doing a lot. So I think I will ask one more question, and then we will take the Chitra has been typing some questions. So technology. So how can technology help the aging population? Have you seen any helpful technology, especially in the context of dementia?
Yeah, as far as technology is concerned, I think it's really something which will help, at least in connectivity with people who can't reach out to us maybe on a daily basis. That is number one. Number two, there's a lot of technology which is happening in different ways. For example, screening of cancers. People are having camps in particular, sort of in a setting of rural areas, and trying to screen them for cancers through technology. Then retina scans are sort of helping as far as the eyes are concerned, for us to know a better way, especially for retinopathy. And this is again through AI and not necessarily somebody doing. So an algorithm is obviously generated, and that particular, of course, with the help of doctors who sort of help in setting that algorithm. So machine learning is something which is really, coming up. For example, I was also part of this a study in which we were doing beat to beat monitoring, that is through Fitbit. So we were seeing the number of steps, the quality of sleep, and how it was affecting the older adults as they were sort of getting older, and how many steps were they usually actually doing as well. So I think that also helps. As far as AI in dementia is concerned, yes, to be very frank, not directly been uh, in association with a lot of AI for dementia, but I've read a lot of research articles on the same. And yes, I think one of them which came in JAMA, that is American uh, Journal of American Medicine, it basically that showed that there was a predictive sort of value. For example, compared to normal screeners and this, that certain amount of particular older adults, they were able to say that they are at risk of developing cognitive impairment in future. Of course, depending upon that particular algorithms that particular AI. Of course, there will be doubts, there will be convincing which will be needed as far as AI is concerned. The element of human error is negated, but at the same time, putting everything to machine learning is also not that easy. But it's a watertight thing in which whenever it's been developed, I think the most time should be put in, and then it will be sort of easier. And that's why I feel more and more, maybe even for old age, I think more and more geriatricians should be involved in making that particular AI, so that it actually sort of works better. Now another problem with only shortcoming which I feel is the receptiveness of older adults to AI. For example, even when we gave them Fitbits, not everybody wanted to wear it. Even if it was, they were like, I don't want, I already have one watch, I don't want. And some of them were like, we don't like wearing a watch only, so why should we wear? So there were sort of dropouts that you will have. It's a thing in progress, and it should be an important. Robotics have come in transplantation and almost all surgery. So why not AI? In which obviously AI will help us in a predictor. It might not always be a substitute, obviously, at least not now, not immediately. But then if it helps us in bridging the gap between care which is delivered from another place to not people not getting care at all, I think that would be a really good beginning, in which at least they're able to detect cognitive impairment and then try to drive sort of. Because a lot of brain mapping has already been done, a lot of research and that has already been done, in which we see in what particular part of brain is obviously the one which is active, especially through FDG PET, which is done, which is the imaging which is done in dementia, where we are able to know what is the metabolic uptake, and then which part of the brain is sort of affected. So even that is sort of helped in knowing. Now, to what extent it will help us in treatment is something we have to see, because we are only talking about detection through AI now. Whether it's going to help us in a curative way, of course, time will tell. Technology will only improve. If you remember, there was a time where only in Bond movies we used to see, a smartwatch and Pierce Brosnan as the James Bond talking to it. As of now, I can do that too. So
Yes.
obviously things have changed, and it has taken only 20 years.
Yeah. And there are simple technologies like Alexa now. People,
Yeah.
older
In
people
fact, there
can
have
use.
been studies through Alexa and older adults as well.
Yes.
Even that is sort of working. Then there have been, there have been sort of course, this is all in Japan, in which artificial robots, especially in the form of animals, even they have been tried with older adults. So whether it works or not, because Japan has, to be very frank, a huge elder population, and not everybody has a younger person to take care of them. So even
Yeah, it makes sense, because a lot of people living with dementia, they find it comforting to have
yeah.
even
As there is
dogs.
in the chat box, it is more of therapeutic, is what I would say. Therapeutic robots are what, and it's really sort of come in now, because that's what they say. Can they substitute the, for example, this a human being there? Difficult to say, but because the algorithm will be there, they will be. I don't know if you know about this. There is a cartoon. I don't remember. It was there's a series also which is coming, which is known as Baymax. So it was about a robo which is a saving robo. So it's
Okay.
so it saves. So in any emergency happens, it saves. So it was basically a manifestation of AI. So I mean, I think at some point of time that can happen, but again, the same things like whether the decision making at that particular time, will that be taking into consideration all the things or not? Like we also in between, if you remember, we were thinking of drivers, robotic drivers for cars as well, but then we had a bit of drops there where there were accidents. So everything is sort of a work in progress. But I think AI has a significant, especially now even more so. I think the pandemic, people have even thought more and got into more and more technologies which can be helpful, rather than them being only in sort of a beta mode wherein they might feel that it might work, might not work. So I think, I mean, it's the policy, I mean, the possibilities are quite exciting. And if they can intertwine both the human element and the AI element, I think that would be the best, if the balance is maintained, and that would really help healthcare overall.
Yeah, you mentioned AI quite a bit, and Chitra Durai, who founded Amicus Brain Innovation, she is a well-known AI scientist, and whatever little I know about AI is from her. One of the things that you mentioned is, it can make mistakes. It doesn't have common sense, contextual, relating to context. So I will hand it over to, there are a few questions. So thank you so much for, so patiently giving us all this valuable information. So Chitra or Shri, I don't know who is going to take over and ask the questions.
Yeah, I can take over. Thank you. Thank you, Dr. Prem, for an extremely educative talk on geriatric medicine, aging well, and dementia, and how you advocate for a holistic, comprehensive care for our elderly, and you define the health as a combination of mental, physical, and social well-being. So thank you, and thank you, Geeta, for facilitating an insightful conversation. An important message from Dr. Prem I'd like to reiterate is you have to manage when you cannot. It's not always possible to treat. So be empowered to discuss memory problems. So get comfortable with starting a dialogue with your healthcare provider. If you observe any changes in memory or increase in confusion, a geriatrician is the person to go to. And one thing that related to our goal as well is, you said searching on Google for answers can be scary, right? So getting trusted, high quality information immediately and when and where you need is it's a time consuming task, and we always worry where those answers come from. So Amicus Brain has those AI-powered advisors that provide the knowledge, advice, and resources, and also a safe and a private community where you can always engage safely and securely. So I'd request everyone to please check out our website, amicusbrain.com, and you can request a demo of our AI solutions. So now there are some questions already on the chat for Dr. Prem. But Chitra is here, so I'll let Chitra ask the question herself.
Yeah, can you hear me? So let me start with thanking Dr. Prem. We have seen you very active in the different settings, advocating for the patients and raising the level of awareness. So we join you in those efforts. So I want to start with our appreciation of what you do out, and also for your time today. So it was, I think besides neurology, geriatrics is important, is a very important aspect of aging care. So I just lost my mother, just about 4 weeks ago, to Parkinson's disease-led dementia. And my father is now ailing with, so this problem is very close to my heart, just like, Geeta has cared for her father. So we have personal experiences of what the journey could be, and that's what makes us get up every day and do this job to make the lives better for others. that they don't have to go through what we are going through. So I had a number of questions. Let me just start with this Parkinson's, especially in the Indian context, because my parents are in India. So looks like it starts with Parkinson's disease with the muscular motor skills impairment. At what point does it turn over to exhibiting more dementia-like symptoms? Is it inevitable, or is there a way to look out for that so that we can actually teach people caring for Parkinson's disease to have a better protocol in mind, what they need to be? It doesn't have to be necessarily that the Parkinson's disease patient need to go through dementia symptoms. So can you help with what the latest research in geriatry is about here?
Yeah, I would say it's not always that everybody with Parkinson's will sort of get dementia, but usually it is said that maybe around 10 years after the diagnosis is where it might happen. And usually the prognosis after diagnosis of dementia is not much. I mean, it could be really rapidly going, maybe in around 8 to 9 years, there might be the inevitable death, of course, because dementia with Parkinson's is very difficult sort of to treat. Of course, there is a type which confuses it, that is dementia with Lewy bodies, which can be very similar because there will be the rigidity, but the only differentiating factor obviously will be there will be a lot of hallucinations and a lot of mental, psychological behavioral changes as well, which are known as, of course, the behavioral symptoms of dementia, which is behavioral and psychological, which are the BPSD as we call, which are always difficult to sort of treat as compared to the dementia per se. But I would say usually a person with Parkinson's not necessarily should have Parkinson's disease dementia only. There is no rule says that they cannot have Alzheimer's as well. So most importantly, it is about, of course, screening them for the same, but in general, there is slowing, there is obviously the motor skills go, the speech is affected, the handwriting is affected, and in general, the quality of life is already poor. So I think it makes them liable anyways for a further sort of, you can say, because the usage is also not happening much. Whatever they do is going to be very, very slow. I mean, you must be knowing from personal experience as well. But the fact that not everybody gets dementia, I think that is important, because it's not a generalized statement that we can say that no, everybody with Parkinson's will get dementia. But the biggest problem that we have is usually with Lewy body dementia, because if it's Lewy body dementia, then it becomes quite difficult, especially for the caregiver as well, because it's a lot of behavioral component, and there could be a lot of restlessness, aggressiveness, and it becomes much difficult to handle as compared to maybe the normal dementia as well, because normal dementia, the quality of life might not always be affected to a great extent. For example, someone with Alzheimer's might not be necessarily bedridden, because they might not necessarily have tremors, imbalance, rigidity. But a person with Parkinson's and dementia is very difficult to handle, purely because the quality of life is already bad, and then on top of that, getting dementia only sort of makes taking care of them very, very difficult. I have also personally seen, one of my close family members, not direct, but just, it's just that after a certain amount of time, the fall happens pretty quickly. So once they are bedridden, and then it becomes very difficult, because the disease does not, again, it's a degenerative disease we are talking about. Parkinson's is also a degenerative disease. So there is we only control symptoms there. There is no absolute reversal. Of course, deep brain stimulation is something which has sort of come in, but again, the ideal candidate for the same is something which would be very difficult to say. It is something that the neurosurgeon along with the neurologist together usually do decide, and but then it has its risk. Of course, you're putting electrodes. So things have got better, but then again, when the diagnosis happens, and then when the Parkinson's dementia is going to set in, usually 8 to 10 years. So you can't really say that everybody will have it. And there is no generalization in medicine, because the day you start doing that, then you lose the battle, because you stop thinking.
Yeah, I asked that question provocatively to make sure that everyone hears your answer as we spread your webinars. So as I look through, my mother's life, this is every caregiver's regret, right? What could we have done differently? Could we have? So one thing is that increasingly I feel convinced that there need to be a standard protocol around memory screening also. Do you agree with that? Just like we have now, BP is getting measured in every internal doctor's visit, and mammogram or de-rigor, and colonoscopy at certain range. So what's being done, and what can we do to, we are a technology company, you're a physician, and how do we move the needle on having this healthcare policy? What's being done there?
Yeah, as far as India is concerned, I think more and more dementia clinics have been professed, especially in multiple levels, not only in the urban setting, but also in the rural setting. So that detection of memory loss, obviously, which is one of the parts, dementia, can be done at an earlier stage. Cognitive impairment can be obviously detected at an earlier stage as compared to it happening much later, which obviously affects the overall treatment. And I mean, in a rural setting, they might or might not be able to afford the entire treatment as well, which is obviously the important call which is to be taken. But I think, yes, I think as far as screening is concerned, I think memory testing should be very much a part of the usual health checkup which happens every year anyways. I mean, a lot of older adults are doing that in India. They do a health checkup. So whenever I see them yearly, I obviously do a memory testing. It varies on the setting because we have so many tools. So if we know that there is no symptoms, then of course we might go for a shorter tool. If we find something, then we go for a longer tool. And of course, if we need specific intervention and strong suspicion, then of course we do a neuropsychological assessment, which is obviously the Eden-Brooks, which is a detailed sort of looking at every domain. So I think that's the way the approach should be. But my most important thing would be that even a person who feels that their memory is normal should also get it screened. The reason being, screening is a generalized sort of thing. It shouldn't be for people who have symptoms only. And a lot of people have sort of come to that and even been sort of, I will say, at peace, saying that, okay, I don't have memory problems. I was thinking I am having forgetfulness, but I don't have. And even everybody who has that particular forgetfulness, also there is a treatment to the same, or there's a strategy to the same, especially trying to basically using memory aids, or obviously trying to again and again writing it down. I mean, when we were kids, we always used to write down things. And now technology is obviously, I mean, there has been a downer as far as that is concerned. All the phone books are only on the phone. And nobody really writes it down. Whereas before, everybody used to write down all the numbers with actually the alphabets from A to Z. So, and people used to remember that also because it was written down. So I think that is something which we need to bring in. The basics will always remain the same. And I think even tags, like marking things which are usually used, make sure, especially older adults shouldn't keep things which are easily accessible, which should be easily accessible at very higher planes. It should be in areas where they can actually see them. So all these things will only reinforce people with any sort of memory problems. Then and then reminders or something which can be both, I feel, technological also and even manual also. For example, the phone telling them to take a pill, and at the same time they're writing it down. So that reinforcement, I think, is very important. It shouldn't be only one type of reminder. It should be reinforcements throughout.
Yeah. I wholeheartedly agree that we need to make this as part of the standard protocol, because people end up seeing their primary care physicians. I'm in the right age group where I have not seen a geriatrician. Probably I ought to be seeing, right? But that never comes up in the primary care physician setting. While she checks my BP and rest of the blood work and so on, this never comes up. But now, having been sensitized to the disease and how early it can, probably I need to have a memory screen. So anyway, so I think we all need to, what I'm taking away is we need to reinforce and we need to spread the message to people that it's just part of the standard protocol to, just like we get mammograms done, just to know. So in that regard, so as you know, Sri and Geeta have been, informing you, or probably you looked us up. that we are a technology company entirely devoted to changing, how the care management is being done, providing all the technology tools and tips, both for people living with dementia as well as for caregivers. So we want to improve the self-efficacy as well as reduce caregiver burden. And one thing we are bumping against, and I think this is true of all technology companies in this space, is the adoption and the barriers, especially. So I can see, the millennials and Zoomers and probably even Gen Xers naturally taking to it because they are born in that phone, age. Whereas, what happens? What are you seeing in the practice? Is there some insight you can offer that we can use to convince older generation, not the ones who are already eager and adopting? I think I see a normal distribution. There are always people who are going to take to the latest app and so on, and there are people who will not be. But the bulk, how do we move the needle on that? Since you're seeing older age group patients, I would love to hear from your experience. What would you use as a persuasive argument or point to have them check any technology out, not just Amicus Brain?
I think with older adults, one of the most important things is that what do they get out of it? I think that is the bottom line. By that I mean the benefit. So whether it's the benefit of sensitization of disease, whether is it a benefit of prevention of the disease, or whether it's a benefit if they have of the treatment of the disease. So basically by benefit, I mean, see, for example, whenever an older adult wants to invest time into anything, they always, because these are educated, experienced people who have got through life and who have done everything and anything possible and have faced any sort of problems. So one of the most important things that I would say, which I've seen from my practice, is the bottom line for them matters a lot. It's not, there is no inertia to technology because learning has no age. So people learn, that's not going to be a problem, provided the learning is given to them with utmost patience, because not every older adult is going to take it up at one particular speed. Somebody, for example, who's already technologically, already sort of strong, will take it up pretty quickly. But others might take their time and they would not want to sort of even they would want to even wait on it. But what would be is, when you try to teach technology, any form of them, it has to be done with utmost patience. And that is where, along with sensitization of what the benefit is, I think that is the most important thing as far as any technology or anything with older adults is concerned. For example, if somebody goes for a health checkup, that is a bottom line in it, that everything, the blood investigations are done, whatever the geriatrician might see, and these are the things you need to do as far as lifestyle is concerned, these are the things you need to do as far as diseases are concerned. Or if you don't have any diseases, then these are the things you need to do for maintaining your health. So I think when there is that kind of a plan, that is what really helps older adults. So clarity matters them to a lot, for them to invest their time and even to a great extent money, because I think that is something which is very, very important with older adults. And I think it's not only about the older adults, because not every older adult is actually the decision maker. It is usually their caregivers, and they could be of any age group. It could be a grandson who's taking the decision, or it could be the child who's taking a decision, or it could be a friend who is taking a decision. And most of the times, I think it's convincing them that becomes difficult, or it's either way. You convince the caregiver very easily, but the older is like, well, what is the use? No need to put all this money into all this, or what is it going to benefit? Forget it. So the caregiver will be very easily sort of. So most of the cases it happens that way only, because I've been independent for 80 years. Why do I need help? Forget it. Forget about it. Why do you want to waste your money? And that's how it goes. And then ultimately it gets killed there. So I think more than anything, sensitization has to be with utmost clarity in the language that they understand, because in India, language barrier matters a lot. Across, for example, the city of Mumbai, in one area itself, you will have 4 or 5 languages. So that is also something I think which is very, very important, because most people it's not that they don't know English, but they would want to converse in the language that they prefer. And I think they have that right because they have reached that particular age in which they are going to be conversing in that particular language. So I think that's what I have sort of, to be very frankly, learned, that there has to be a purpose or there has to be a goal to it, and they have to be convinced that is there. Usually just saying, I mean, for example, if you're going to a younger crowd, even you telling anything about an innovation will attract them. It's not necessarily going to attract older adults. It's about results for them. It's about how it's going to change their life. It's about how it's going to add to their life. I think that is very important.
I have a question. So I know I follow Graceful Living. I think you're a founder of that. Do you have programs where older adults get exposed to technology? And because you brought up something that needs a lot of patience. And I had my parents living with me, and my mom was very quick to pick up the iPad. In fact, she took my iPad over and it was hers. And whereas my dad, he would sit on the old, computer, and he just couldn't get it. And I was not a very patient person. So sometimes if there is if something like Graceful Living or another, daycare or something like that, which offers programs like that, that would be an incentive actually. Where they have a methodology, to teach them.
So basically what we did is we actually took the effort of training them in technology.
Okay.
So Zoom training was provided by one of our trainers, and this was done online. By online, I mean through phone first, trying to tell them if there's a younger person around, and then try to train them through them. If not, then personally train. So that was quite painstaking, and they did it. And then as we saw, then the numbers of our even support groups kept on increasing because more and more people were comfortable with their technology. Of course, there were the usual mutes and unmute problems, which are always sort of the case. But they sort of adopted to it. So I think it took time. Obviously, it took time. Yeah, I mean, the pandemic started in 2020. We are in 2022. So 2020, a larger part of it was put into actually training them in technology. So, I mean, we sort of can say those results are very clear to see that the numbers are obviously more and more now. So it is not the lack of the fact that they don't want to attend it. It's just that they are not able to because it's not that they're technologically challenged. It's because they have not been taught. I mean, nobody has really put in the effort to teach them.
Yes. Yeah. So very good. Lots of great insights, Dr. Prem. Perhaps we can follow up offline out of this webinar
sure.
with you, and give you a demo of what we have built and get your perspective on how we might put that. Our goal is to not just develop technology, but actually have that used and benefit whoever needs that value you talked about. So thanks again.
Yeah.
Over to you, Sri.
Oh, thank you very much.
Thank you, Dr. Prem, and thank you, Geeta. Thank you, Chitra, and all the participants for attending. If there is any other questions, you can message us, and then we'll convey to Dr. Prem.
Thank you, Geeta, again, Dr. Prem again, for the gift of your time today.
Yeah.
Thank you. Bye-bye.
Have a nice evening.